Pure urology viewers, good evening one and all. As you all know, the RIRS has picked up in last 10 years. Even myself, I am doing for last 18 years. And most of the fellows who come to us, they learn within 2 months. It is easy surgery than PCNL. But at the same time, lot of people say that you will get fever, you will get ureteric stricture, you will get residual stones. Yes, it is true, provided if you learn properly and practice properly, the complications are disastrous in any procedure. But I must tell you, RIRS is a relatively easy endourological procedure. Previously, the scopes were very costly. In government institutions also, once the scope is lost, again buying the scope is difficult. But now the era has changed. The disposable scopes have come. Forget about advanced surgeries like fans. Basic RIRS is becoming a norm. And to talk about it, today we have Dr. Kartheek, who is consultant at Preeti Hospital. I have seen him joining for last 1 year. He learned very fast. And he is also aggressive and tried to do a lot of the stones with RIRS successfully. So I thought in this 1.5 years, he might have seen some of the problems where myself, Dr. Ramakrishna might have helped him. So I thought let we listen from him only what are the common problems when you are learning phase you will face. I requested him to talk on this. So to introduce about Dr. Kartheek, his topic is common mistakes we do during learning phase of RIRS. I consider him as 2 years consultant who has done a lot of RIRS. With that, he is able to lead the hospital also. So Dr. Kartheek Ganapathri is MBBS, DNB and Dr. NB Urology. Consultant Urologist, Preeti Urology and Kidney Hospital. MBBS he has done from in 2006 in Chalamada Anandarao Institute of Medical Sciences, Karimnagar. DNB surgery he did from South Central Railway Hospital, Hyderabad. DNB Apollo Hospital, Kolkata. Gold medal in urology. Academic Achievement Award for Bengal Urology Society. He presented paper Improvement in LUTS and Uroflowmetry with Silodosin. He moderated video presentation in USICON 2024 laparoscopic pyloureterostomy for lower pole PUG obstruction duplex system. His paper presented in moderate poster session in video endoscopic bilateral inguinal lymphadenectomy. He is academic oriented and he is interested to learn new things, works hard for that. He is evolving in his career. I just wanted to listen from a relatively junior who has started 2 years back and learned, so that it will be useful for the juniors. Once you acquire mastership, there may not be anything to learn in this talk, but lot of youngsters are coming. Urologists are joining across the world to learn the RIRS. So let us listen from him. What are the mistakes we commonly do, which we should not do? Kartheek, over to you. Thank you.
Yes, sir. Thank you, Chandramohan sir, for kind invitation. And actually, sir, as sir told, I joined the Preeti Urology Hospital 1.5 years back. Under his mentorship only, I learned RIRS surgery. So in this beginning phase, I did a lot of mistakes and a lot of enthusiasm. So in this my eagerness, I did so many mistakes. So but I learned from those mistakes. I corrected myself. I'm very thankful to Chandramohan sir and Ramakrishnan sir for giving this opportunity and mentoring my academic life. And right now, I'm going to start the presentation, sir.
Yeah. We are able to see you and we are able to listen you. Proceed.
Yes, sir. So my topic is what are the common mistake we do during the learning phase of RIRS. So learning phase of RIRS is very difficult for the experienced phase. Experienced people will think everything is just small things, minute things. But as a juniors, in that phase, we'll struggle a lot. The common mistakes we'll do and we'll face it. serious consequences and challenges. So what are the common mistakes as a junior, as a learner? First, we'll do in RIRS, we discuss. Then afterwards, what are the learning points to be learn from those mistakes and how to correct and how to evolve in a surgical career. So most of the times when we see any small stones, anything, we eagerly jump to the RIRS surgery because we are enthusiastic enough to do the surgery. So in these things, we will miss minor details like reading the CT properly. First of all, we should analyze where the stone is there, or what volume is there, in which calyx it's located, and what is any abnormality of the PCS as such. So which will lead to complications of RAS. We may not reach the stone. And what is the stone hardness? So we may able to complete within 1 hour, or it's going to take the more time. This is important because from this we can counsel our patients. So it may require two-stage surgery, or it may require it may complete in a single-stage surgery. If we tell the patient that we'll complete in a single setting, if we tell again that it may require second stage in the later date, it won't be nice. So preoperatively, we can counsel the patient depending on the stone parameters. So we'll avoid any unnecessary complications. And for example, any large stones which are in the inferior calyx or anything which is going to difficult with RARS, if we assume that it may lead to RARS may be difficult in this case, in those cases, we can plan for the PCNL also, and we can counsel the patient accordingly. So it will avoid any intraoperative hassle we'll face. So once we said patient can be done without any scars, anything, then we do the PCNL surgery. It's very difficult to explain in the post-operative setting. So, but if we explain the in pre-operative settings only, the patient can be understand. So we to avoid with any post-operative unnecessary complications. And most of
what is the CT finding which will mislead us?
Sir, if the counts, CT cuts will be bigger if it's less than 5 mm. If you're taking more than 7 mm cuts, stone may look very small, sir. So we assume that it's a small stones, we'll go and pick up the stone as soon as possible. So, but once we enter inside with this magnification of the scope, the stone may look bigger. And one more thing is stone hardness also we can have to consider, sir. If it's really hard stones, even though laser is the strongest energy, it will take more time. If
What
you
do you
spend
think more than what size in the initially if you take, you feel that array this is too big and I cannot able to do 1 centimeter, 1.5, 2 in the beginning?
Sir, actually, according to UD guidelines, it is suggest 1.5, sir. But beginner, it's around 1 centimeter stone is adequate, sir. To avoid unnecessary.
Correct.
If you are not able to do 1.5 centimeter stone, sir, it will decrease our confidence level too also, sir. And if any complication, post-operative sepsis, our enthusiasm will go. So better to select a simple case with a smaller stone size in the initial period will be beneficial for the junior consultants, sir.
Do you think that CT is enough, or sometimes X-ray KUB will give better idea?
Yeah, yes, sir. Actually, as discussed, sir, if the CT is taking a longer cut, it will decrease the size of the stones. If we don't check the report, we go with the CT film, we carried away that this stone might be very small. We can talk it off that. So report the radiologist measure and give. So we can always have a look on the report of the CT. Then the ultrasound really helpful in the everything. It's a not an investigation as such. It's an examination finding. It's an extension of the examination. So as juniors, we should be well versed with ultrasonography. So once ultrasonography, it will give three-dimensional size of the stone and a real size of X-ray KUB. It's very real for that. It's very cheap, less economical to the patient also. It will correctly assess the stone size especially.
So you recommend initial phases, plain CT and X-ray KUB better, so that you will get some idea whether you are dealing with big stone or small stone.
Absolutely, sir. I will recommend that, sir. X-ray KUB, it's not costly investigations. We can counsel the patient that once CT is done,
And preferably X-ray KUB, you should be a bigger one.
Yes, sir.
Correct. Because
real size X-ray.
If you take a compressed X-ray, again it looks small.
Yes, sir. Absolutely. We won't get much
information. To see the size of the stone and volume of the stone, and better to take a small volume, small stone in the first 20-30 cases.
Especially, sir. So that will, if we complete the 20-30 cases without any complications or without any help, no, sir, that will give a lot of confidence to juniors, sir. So correct. Initially going slow is the better.
Correct. Next.
So once we assess the size of the stones, I am very comfortable. This is the small size stone and I can easily reach the calyx. Then I will plan the patient for the RIRS surgery, sir. So while doing the RIRS, most of the times, my initial stages, sir, I am very eager to do the RIRS surgery. So sometimes in the enthusiasm, I forgot to do the ureter, sir. Calibration of the uretoscopy, we miss. So we don't know what is the ureter caliber, whether we are able to pass the access sheath, anything. So we may face difficulty that time. So before doing any RIRS surgery, first you have to calibrate the ureter with 6 by 7.5 scope. If the scope goes easily, there is a lot of rugosity is there, and it's a distensibility is the most important factor, sir. If the ureter is getting nicely distended, in that case, we can pass the access sheath safely, sir. And this scope is 6 by 7.5 because if it's admit, we can pass 9 by 11 sheet. 9 by 11 sheets. Sir. And sometimes, even though we pass the uretoscope release, sometimes due to edema, anything, we are difficult to pass ureteral access sheet. In these cases, in the beginning of the career, it's better to give a stent and come back and go after 2 weeks. It's better, sir. And most of the times in the
Don't put
freelance.
the access sheath forcibly.
Yes, sir. If access sheath also is semi-rigid, it will injure the ureter and mucosa. So you should not fix it. If it goes freely without any resistance, and then we can go for it, sir. Otherwise, you should not keep anything. And
What
most
size
of the
of the
times,
access sheath normally better to use in the beginning?
it's 9 by 11 sheet, sir.
9.5 by 11.5.
11 sheet.
Yeah. Okay.
And most of the time, sir, I've seen my friends who are junior will they hire a ureteroscope, flexible ureteroscopy and a laser from outside. Even though they don't do the case, we have to pay for it. So in that thing, they will do the sheathless RIRS. So without passing the sheath, they will try to pass the flexible rhinoscope directly into the kidney. But in the beginning of a stage or any time, it's better to be avoided because there will a lot of chance to increase the intrarenal pressure, increase the temperature and ureter damage, and we may not clear the stone completely.
Do you think the flexible ureteroscope also can damage the ureter?
Yes, sir, 100%. I have the one video also. I will show you. It is also damaged. It is, even though it's so much flexible, the tip is somewhat semi-rigid, sir. So it will damage. If we should not blindly push the flexible uretoscope thinking it is so much flexible. It is not so flexible, sir.
So the tip of the flexible scope is rigid.
Semi-rigid.
Correct.
So I'm showing the video, sir. How can you say it's a good caliber ureter? So in this ureter, we are going with a ureteroscope with help of a guide wire, 6 by 7.5 inches. You can see that's a lot of rugosity on the ureter, and the ureter is easily distensible. So in this kind of ureter, we can safely go with it. And once the ureteroscopy is done, always never forget to keep the safety guide wire. So in this safety guide wire, it will straighten the ureter. And is there any undue complication with the ureter sheath or any mucosal perforation, any flap? So we can safely navigate through this guide wire into the PCS. If it is too much bleeding, we are not able to see anything. In that case also, we'll just stent and come out. So always keep a safety guide wire in every case.
Correct.
And some ureters, even though they're okay admitting the 6 by 7.5 scope like this, you can see that paleness of the ureter and that's concentric ring. So when that feels that the ureter is not that dilatable or accommodable. So in these cases, you should, in the initial stages of the career, don't mangle up the ureter, just keep a stent and come out.
Kartheek, I will ask a question.
Sir.
When you put the ureteroscope, how will you know that the ureter is adequate or not? One thing is you pass the ureteroscope and see.
Yes, sir.
Passing the ureteroscope by seeing the lumen, can you say that it is wide lumen or small lumen?
Yes, sir. If there is a lot of rugosity and the distensibility, sir, with the water, if it's able to distend freely, with this we can say that the ureter is accommodable, sir. The sheath can be, we can keep the sheath.
One more point I will add. The lumen of the ureter, don't mind.
Yes,
The
sir,
lumen of the ureter, if is close to the outer surface of the monitor. Here you are in this monitor, it is close to the outer surface of the monitor. It is a big ureter. If the lumen of the ureter is half of the monitor, it is like a small hole in the monitor. It
yes,
is
sir.
not a good ureter. You are understanding now?
Yes, sir. Yes, sir. Absolutely,
the
sir.
Ureteroscope, the lumen of the ureter, if it is completely filling the monitor, it is a large ureter. If the lumen is half of the monitor. Lumen is half of the monitor. It is a very small ureter. That is also a
Yes.
point. Okay, next.
So as you mentioned rightly, that the ureter access sheath can also damage the ureter. So
Okay.
when the ureter access sheath is not going freely, we should check one more time. What is the reason it may be due to? Any edema is there anything? We should not blindly push the access sheath, but thinking that 6 by 7.5 scope is easily going, it will also go. So it's not always the case here. So either showing this is the case that the mucosal injury of grade 2 by ureteral access sheath, sir. You can see that. So this ureteral access sheath also can injure. So we should be very careful in passing the access sheath. Whatever the method you can choose, but it should be with gentleness should be there.
So do you think that new ureteric access sheath passes easily than old?
Sir, especially, sir, yeah. I had seen you and Ramakrishna are doing a many things, sir. It's not for the beginners, sir. But when it's not going, you people are trying with the new sheath, and every time that time you people are successing, sir. That's why I observed, and I didn't do any time, sir.
Yes, better not to do. But if you have a new sheath, your benefit of doubt, use the new sheath, because the outer coating is very smooth and memory will not be there in a non-reused one. So you can easily pass straight. The smooth thermo coating will not be disturbed. So if you are in a borderline case, for example, 6 by 7.5 has gone, then if the access sheath is not going old one, if you use new one, it can go. But that also you should not apply too much pressure. Very
Yes, sir.
good point. Very good point. Next.
Sir, while doing the ureter scope, most of the time we'll encounter the upper ureter impacted stones, sir. So while planning the RIRS for the upper ureter impact stone, we try to push back the stone. So in impacted stone, always using pneumatic lithoclast. However, the junior consultant who are recently practicing, how may they expertise in the laser energy? So they always try to use the pneumatic, because laser will cause us so much of complication. There is a bleeding and thermal injury. It's always advisable to avoid laser lithoclast in the upper ureteric stone or any ureteric
Laser,
stone.
if in pneumatic, if you bake two pieces and both of them go into kidney, is it okay? You are comfortable with that?
Yes, sir.
Very good. You are comfortable.
Because laser,
Nothing
yes,
will happen. If two
yes.
pieces go into kidney, you can go take them, put it in one calyx, aram say you can do it. But laser, especially, do you think if you want to use laser, first of all, you are telling don't use laser in upper ureteric stone or anywhere in the ureter. If you can use the pneumatic, that is better. It is not question of afraid, or it is not question of not able to do. We are all doing it. But what are the conditions where laser is useful in ureteroscopy with your experience?
Sir, if its ureter is very much dilated ureter, sir.
Very
So
good.
in this case, we can fragment the
Very
ureter.
good. Second, very small stone, not moving.
Yes, sir.
And if it is pneumatic, it may move
Yes,
up,
sir.
move up and down. If it is a small stone, you make it 2-3 pieces and take out.
Yes,
But
sir.
not densely impacted stone. If at all you wanted to use laser in a densely impacted stone, how will you use?
Actually, we'll go through the stone, sir. We don't try to touch any walls or any stone containing the walls. We'll try to core through some a little bit in the center of the stone. We want to fragment.
Is it easy?
No, sir. It requires experience. So I'm telling this by juniors better to avoid in the initial phases of the.
Especially with respiration, spinal anesthesia, even if you are meticulous, suddenly patient take deep breathing, you may activate the laser, you may touch the mucosa, isn't it?
Yes, sir.
Yeah, it is difficult, as you said. Core through is not easy. After 30-50 cases, whatever through you can do, there is no problem. But first 50 cases, pneumatic pushback, do RIRS after stenting. Okay,
Yes.
that's a very good point. Next.
Showing one of the case here where the upper ureteric stone is there. It is not as such densely impacted.
Okay.
So the surgeon used the laser energy to fragment the stones. And in grossly, there is no contact of the laser with the mucosa. There is small damage to the guide wire. That's okay. But as such, there is no bleeding and there is no touching of the laser energy to the mucosa. And after that, they fragmented. Case went well smooth. The fragments are also extracted. Patient kept a digestant. And procedure is not uneventful. There is no any complications. But after 3 weeks, when they relook for any residual stones, so this is the thing they noticed. There is a complete narrowing of the ureter, only able to pass the guide wires.
I
So
told
this
if the lumen is half, less than half, are you understanding this?
yes, sir.
In the screen, if the lumen is less than half, it is a very severe narrowing. You should not attempt ureteroscopy, put a stent and come out. This is a severe stricture.
Yes, sir.
Pale mucosa, no blood vessels. It is because of heat. We should not see these type of strictures.
Yes.
Okay, next.
So after keeping the sheath, we want to pass the flexible uretoscope, sir. Before and we discussed that flexible, don't think the flexible uretoscope is so flexible. So always pass the flexible uretoscope under vision and try to navigate through the curves of the ureter. If blindly you push, it can damage and it can perforate the ureter also, sir. In case of any difficulty, try to pass over the guide wire. You can do the railroad and you pass the guide wire. So I can show the case where this flexible ureteroscopy cause injury to the perforation of the ureter. So this is the upper ureteric stone right side with a kink in the ureter. And the ureter is tortuous. Navigating through the curves will be difficult. With the help of the guide wire and the ureteroscope, we are able to go through. And there is an acute kink in the upper ureters, where initially passing the guide wire is also difficult, but we are able to pass the guide wire. After that, with the flexible ureteroscopy, we are not seeing any lumen. When we try to push this, there is a damaged mucosal injury with a little slight perforation also, sir. So these kind of cases, when passing flexible ureteroscopy, you can see that so in RGP, there is a contrast fixation also.
Absolute perforation.
Yes, sir.
Very dangerous.
Yes, sir. So we don't think that flexible ureteroscopy is so much we can pass blindly. Once the access is inside, it can navigate on it own. That thing should be avoided, sir, especially. And it's always better to operate anything under vision in endoscopy. Once we pass the flexible ureteroscope, so we are in enthusiasm in the learning period, sir. We want to finish the case first. So we try to fragment stone as soon as we go enter into the PCS. That should be avoided, sir. Once we go, it's always wait to progress. So first, let all the sediments or minor woods, anything will be little settle down, and the water column has to be established. There should be clear water outflow should be there. That will increase the visualization of the PCS better. Then afterwards, we should inspect all the calyxes for containing the stones. Which are the calyx which contain the stones, and how many stones are there, where they are situated. And we take a moment to understand the pelvic calyx system anatomy also. Whether it's a duplex kidney, any calyx is awkwardly placed, whether any malrotation is there, anything is there, we try to identify. Then we'll select the favorable calyx. So, and once we fill up this favorable calyx, any stone, any calyx with acute angle containing the stones or small stones, we try to basket from that calyx to a favorable calyx before going for the fragmentation.
So you first finish the small stones?
Yes, sir. Always first the small stones we have to finish.
Why?
Because sir, if you break the large stone, there is so much of dust will be, the dust and fine dust will be accumulated, which may obscure the small stones. So that the stone clearance rate will be less. So always begin with the small stones first.
Very good.
So this vision is implied when we are to the favorable calyx. So favorable calyx means our scope should be at a neutral angle. There should not be any undue flexion or undue extension. Any extra manual should not be required. So initial stages where the inferior calyx, where the deep calyx is there, we try to go flex too much there when we lose the scope so many times. So that thing should be avoided. So once we did identify the favorable calyx, we try to pass the laser fiber. So, and always make sure that the laser fiber tip should be visible. And you should not, that blue tip should not be removed in any case. That blue tip should be, helps in identification that how much fiber is away from there and where we are exactly firing the laser. So it will avoid the damage to the...
Removal of the blue fiber is outdated.
Yes, sir. So this thing, it
has no meaning.
Yes, sir. And the blue tip doesn't affect with the removing or keeping the blue tip doesn't affect the efficiency of laser. Laser will be same with the tip or without tip. So it always be used with the tip. So we will be cautious. We'll try to avoid the ureter or PCS, or we should not damage the scope. We inherently we don't fire laser inside the scope. That is determined. And there are so many lasing fragmentation method will be there, fragmentation, dusting, and popcorn. So which method where we have to use should be we should understand ourselves before, sir. And before starting the laser, most of the people will ask, what is the laser you will use? What is the thing? And it is not a hard and fixed rule, sir. We will start with the laser energy. Depending on your mission, we always start with a lower energy setting. And after 5 minutes of the lasing, we'll understand ourselves only whether we should increase the speed depending on the fragmentation route, or we should decrease the laser energy, anything that. So we should identify our own settings in our clinical practice.
Correct. Use low energy, low frequency, then increase.
Yes, sir. And this is the dusting method. Mostly we will see 0.1 joules and 60 frequency. It is like a painting mechanism. We should not dig at one point. It's all around the stone. We should like a painting. So we should avoid the fragmentation of the stone in the dusting method. And in the popcorn method, once the stone is fragmented, we use high frequency so that the high energy will be there. It will make that smaller fragments into a finer dust. And this popcorning method mostly we'll use in the stone even in the calyx. So there is a less chance of migration of the fragments will be due to other calyx.
Can we do popcorn in pelvis?
No, sir. Popcorn will lead to a lot of fragments will migrate into all the other calyx. So the stone clearance rate will be decreases and a lot of dust will be accumulated. So visibility
if you have a
decreases.
stone in the pelvis reasonable size, what should we do? Only dusting?
Only dusting mode we should choose, sir.
If you wanted to do fast?
So we'll fragment and we relocate the fragment to a calyx, then we'll go for the
Absolutely
fragmentation popcorn.
That is the most important point. You do dusting better in the learning phase. You do dusting in the better learning phase. You learn dusting, you do painting, slow movement. Once you learn that, you are master. After that, by chance, if stone becomes two fragments, don't try to make fragments in the pelvis. Put them in the calyx, and then you can dust, you can fragment, you can pop dust, you can popcorn. Whatever you do, stone cannot escape. So, is it the dilated system difficult for RIRS or compact system, Kartheek?
Dilated will be difficult, sir.
For PCNL?
Dilated will be easy, sir.
Yeah. So, if you have a dilated system with large stone, don't do RIRS in the beginning. Please do PCNL. If you have a small stone in calyx, upper calyx, do RIRS in the beginning only. No problem. You can make 3-4 paces, they will pass out, less than 1 centimeter. But if you have a PUG obstruction with 1.5 centimeter stone, largely dilated pelvis, you can never finish RIRS. Very difficult. Even for experience, it is very difficult. Correct. This point is well taken. You do dusting in pelvis. If you become fragments, put it in the calyx. In the calyx, you can do fast fragmentation or slow dusting, no problem. After some time, you can do popcorn. After some time, you can do bob dusting. After that, you can leave it or suck it, no problem. But in the pelvis, if the fragments go here and there, then unnecessarily SFR will come down. Correct.
Yes. So this is the calyxical stone, sir. So what exactly you told. So in the calyxal stone, we try to fragment first, then we'll use the popcorn energy. So it's a compacted system. There is no place for the migration of the fragments. So we can go a bit fast like that. And in the pelvic stones, it is for beginning stages, it's always better to dusting, taking time. If stone is not so much, just completely powdering the stone is very helpful in the beginning stages.
Correct. This is the way. Now, personally, what do you like? Now you are 2 years. If you are beyond 1 centimeter in pelvis, you like to slowly dust it and enjoy?
No, sir. Now I will relocate it to the any calyx. If you have 1 centimeter stone, I will do the fragment and popcorn, sir.
Very good. Because of what is the reason?
Sir, how much time we spend in the PCS, it increases the sepsis complication and complication to the kidney. So to avoid that, we should come out as early as possible without injuring anything, sir.
Do you think that TFL will help in that?
Yes, sir.
Why? High frequency.
High frequency will be there. So the popcorning will be easy. And in the beginning of cases, some special scenario we should be avoided, sir. Like this kind of thing, multiple stones in all the calyxes are in a different difficult access calyxes. It's better to avoid in the initial stages, sir. So we are not able to fragment, we are not able to achieve complete stone clearance rate. And if the undue flexion is there and any calyx is containing acute angle, we may lose the scopes. So these kind of cases especially avoid in the initial phases.
Correct, correct. Multiple stones are not a good case for RIRS. Correct.
And there is some session we will some separate scenarios we face regularly, sir. So even we keep the access sheath, the flow is good. We will continue with 5 minutes of the fragmentation, but the vision is not going to improve. We don't get a clear vision. Maybe due to it a stone dust, maybe due to a minor bleeding, or maybe due to any infection pus. So in these cases, it's better to stent and come, even though the outflow is good, sir.
Do you think that primary case is easy or post-stented case is easy?
Post-stented case is easy.
Because water flow will be very good.
Yeah, very, very good.
So I have seen one surgeon after getting trained here, he does only in post-stented cases, and his practice is very good because ureteric complication and septic complication he says very, very less.
Yes, sir.
In a third tier city, not in a major city, he does stenting for all the patients. And then happily, and post RIRS, he will not do stenting. So anyway, it is 2 times only.
Yes, sir.
So benefit of doubt, stent. Yeah,
Yes, sir.
next.
And some cases when after keeping the SS sheath, everything is clear, but there is no outflow at all. Even though small stone is there in the primary setting, it's better to stent and come. We should not do any fragmentation, even though stone is small, without outflow, sir. That will lead to septic complications.
Correct.
That water flow should be adequate, sir. It is not like that when you give the pressure, some of the water is coming. We should not think ourselves that the water is coming. The water should be continuous.
Very,
It's
very
adequate.
important. Very, very important. You said very good point. The flow should be clear. It's not like 1 minute, 1 drop, half minute, 1 drop. Then you will be flushing 15, 20 ml. Very dangerous. Very, very important point. Correct.
And most times we face a difficult scenario, sir. After post-stenting also, when we're going for a RIRS, there is within no water flow. So that may be due that that sister might be pushing the access sheath, abetting the mucosa of the ureter. So in that cases, that water may not come. So in that case, we just try to withdraw sheath a little bit. And there will be a tortuous ureter, there will be a lot of kinks will be there. In that also the water flow won't be adequate. In that cases, try to pass the access sheath above the kink. We straighten the ureter with the ureteroscope and guide wire and try to pass the access sheath under vision above that kink. Then the water flow will be increases.
Correct.
And most of the times, as especially young surgeon, think the relook RIRS is very easy as we discussed right now, sir. So the ureter, there is no damage to ureter, anything. So we tried to directly pass the access sheath without any ureteroscope because we're thinking that ureter is already dilated, no need to check. But in a relook cases, there is always some residual fragments which might fall into the ureter. So ureteroscopy from UVJ to pelviureter junction should be must. So any fragment is residual in the ureter, we will take out. And while doing the relook RIRS, you should inspect all the calyces. There is no chance that we can't post the case for one more time. So you should do light RGP and we to inspect all the calyces. When I achieve the 100% stone clearance only, then you should come out.
Okay.
Once we do the RIRS surgery, we finish the RIRS surgery, we again re-inspect the all calyces. So some calyx which may not contain stone initially, but while doing your fragmentation and popcorn, some of the stone can migrate from this stone-bearing calyx to non-stone-bearing calyx. So we should not assume that that calyx doesn't have stones, only lower calyx containing stones. We fragmented, the work is done. We should not think in the initial, so yeah, especially we think like that in the initial stages, sir. That thinking should be avoided. Again, we have to inspect all the calyxes, upper, middle, and lower calyxes for any migrated fragment, especially.
Yes. Inspect all cases.
Yes. And we make first, it's a stone may be solved sometime, but stone may be very hard. Even with the TFL laser energy, we are not able to fragment adequately. If the duration is prolonging more than 1 hour in initial stages, but as we explained to the patient, better to stent and come or consider the option of PCNL, sir. If your duration increases more than 1 hour, there is an increased temperature, lot of edema, and lot of septic complications in the post-operative field. So that heroism should be avoided, and we should be stage the procedure. I will convert to an alternate procedure like PCNL. And once we shoot that all the stones are removed, we do a gentle RGP with a dilute contrast. Gently, we have to inject into all the calyxes. Sometimes in a duplicate system, we may miss some calyx. Some diverticulum may containing the stones, which may miss in the regular flexible ureteroscopy. That calyxes can be identified. And any residual stones, which is containing after the RIRS, they can be identified in the RGP. And sometimes the intravasation and extravasations. So these extravasations are caused by any unidentified injury caused by the sheath or scope or a laser to the PCS. That can be identified in the intraoperative period, so which will guide the further treatment of the patient. So initially in the beginning phase, I used to think that, sir, for the stone, if any patient is asked for the stone analysis, we'll think that a large fragment is required. So we try to basket out the large fragment leading to some entrapment of the stone or a ureteral injury. Thus can be avoided. With the senior guidance, I have learned that that small fragment also and some dust is also essential enough for the stone analysis. So don't try to fragment basket a large fragment for the stone analysis. And when the large volume of stone is there and burden is more there, so there is a lot of dust will be accumulated in the PCS, which may come in our way between the scope and sheath. That will hinder the movement of the scope freely inside. So when we want to take it off, in that cases, do not apply any force. If the scope is not coming freely, there is a limited movements of the scope between in the sheath. Try to come out with the sheath. So in that cases, we'll avoid damage to the outer part of the scope and we'll inspect the ureter while coming out for any injuries. And in the juniors, we want to do
RGP is essential. Somebody asked Praveen Patel, is post-RGP is mandatory?
Yes, sir. It is mandatory. First thing is that we know the complete PCS anatomy. So some duplicate system is there, some calyx is draining abnormally. We may miss that calyx during our whole examination. How many times we had gone inside also, that time you can miss. Second thing.
At the end, RGP is essential.
Yes, sir. At the end, it is essential.
What
and
for?
Second, it will look for any injuries, any intravasation and extravasation, we can make it out, sir. So we guide the patient for further thing. We can keep the stent long time. Is there any injury? Is there any perforation? Is there some contrast leak? Is there anything? So it will guide our post-operative management of the patient. And we are aware of that what it thinks. We'll take the stent little long. We'll keep the stent for a little longer time. So that RGP, we are assured that there is no major injuries.
Yes. Residual stones, how will you, same question by Praveen, that residual stones, if you have after the RIRS, how do you follow with them?
Sir, residual stone fragment by definition, it should be less than 2 mm and it should be easily floatable, sir. But coming to the practically, whatever the size, when we're doing that, we should aim for the fine dust.
So it's more than 2 mm. More than 2 mm is residual stone.
Yes.
Nowadays, any stone 1 mm also, they are saying residual.
It's a residual, so that's what we should aim for a finer dust every time.
Yeah.
And if you think that the small fragments, if it is less than the laser fiber size, it's floating easily in the PCS with the thing, so that can become residual. But as you mentioned, we should not leave that bank and also try to do popcorn little more time. It will make into fine dust.
Correct. Sterilization?
Yes, sir. Sir, we should always ask for the sister how much time she is keeping in the sterilization. We should make that it should be properly sterilized and adequate time is given for the sterilization. Because the most common complication of the RIRS is urosepsis. We should take utmost precautions to avoid this sepsis complication due to sterilization.
Do you put the stent at the end of RIRS?
Yes, sir. Unless it's a pre-stented cases and at very small stones, there is no injury in anything and the ureter is dilated well, then those cases I may avoid by keeping the ureteric catheter for 1 day, sir. But in the beginning stages, it's better to keep a stent every time, sir.
What size? So
we regularly use 3.5 French stent.
Why 3.5? Everybody in the world use 5.
Sir, this stent size doesn't help in anything, sir. Any stent is used for the drainage.
The stones will come out by the side of the stent. So stent size should not be big. That is our idea.
Yes, sir.
The stone, clot, bacteria, urine, everything should come by the side of the stent.
Yes,
So
sir.
small stent is better. 3.5 we use all cases. So only problem with 3.5 is what sometimes it may fall down.
It come out, sir. Yeah.
Yeah. So except that 3.5 as luxury, and we feel irritation to the bladder, irritation to the kidney is slightly less with 3.5. 3.5 is very thin stent, but serve the purpose. But up to 5, worldwide, all senior surgeons put 5 French. Many of the surgeons I have seen 5 French, and many of the Indians also use PCNL RIRS 5 French stent only. We are using 3.5. It's okay, no problem. 5 French also you can use. There is nothing big in that. Yes, next.
That's it. So these are the just what I understood in my learning, sir. So I try to cover as much as possible. If anything, you can guide us, sir.
Yeah. So can we close the screen? Good presentation.
Thank you, sir.
Can we close the screen? Yeah. So normally people ask some common questions. Number one, you worked with us for 2 years now. Unbiased, you tell which scope you have used, disposable scope, which scope you are comfortable.
Sir, I am compared with Bayreuth, sir. That is
Bayreuth.
also, sir, as a learner, it's somewhat stiffer compared to huge med and anything. So I can give some more flexion and everything. So the damage to the scope is less. Scope won't go if you bend more also. But in huge med, if you try to bend more, we don't know which point it will break.
Correct.
That
So
is
Bayreuth slightly durable scope. What laser fiber you are using for RIRS?
TFL, sir, thulium fiber laser.
200 micron fiber.
12 micron.
200 micron. So have you used ever holmium laser?
Yes, sir.
Do you find any difference?
Sir, this thing, it is more, the fragmentation will be very fast with the holmium, but it will get a larger fragment size compared to TFL, and popcorn will better with the TFL.
Yeah, because of the high frequency.
High frequency.
So if you are doing large volume stone burden, if you are doing high volume stone RIRS, TFL is slightly better. You know one more advantage of TFL? Maintenance is free.
Frequency.
It is 2-3 years, no damage in our hospital. So what is the cost of normal disposable scope? Do you know?
So it depending on the 75. This huge med will come 75,000 to 1 lakh.
85, 90,000. Do you know normal cost of the laser mission? Holmium laser mission and TFL mission? You may not be knowing. This
25 to 40 lakhs.
Why we are asking this is cost effectiveness. Whenever you lose something, you feel bad. In the beginning, that is also one mistake. Holmium laser is approximately 20 to 24 lakhs. TFL is approximately 22 to 26. 2 lakhs difference. So in 35 watts. If it is 60 watts, thulium fiber laser is around 40 lakhs. Whereas 60 watts holmium maybe 38 lakhs. So we have to remember that the cost of the scope, cost of the laser also. Do you know that holmium laser blast sheath is present and it goes often? You know, cost of the blast sheath maybe 30,000 to 70,000. So that is also a maintenance problem. So TFL, there is no blast sheath. There is only blast field is there, but there is no sheath separately. There is no damage. Why these are all important is when you are doing a case, if you lose the scope, you feel very bad. One thing is patient safety and your cost economics also you have to see. So if a large stone, if you take in the beginning and first scope you damage, then you lose the interest. That's why, do you think that PCNL is also very essential surgery to be learned?
Yes, sir.
Very important. So if you are a stone surgeon, you should not say RIRS surgeon. You should not say prone surgeon. You should not say spine PCNL surgeon. You should not say ECIRS surgeon like that. All the things you have to learn, use appropriate. What is your present after 2 years? What size of the stone you can manage with RIRS post-tented?
Sir, with your guidance, now I can do 2 to 2.5 with the fans.
Yeah, 2 to 2.5 you are daily doing.
Yes,
So
sir.
anything after 50 to 100 cases, up to 2.5 centimeter with a positive mind to the patient, that second look may be required.
Maybe.
But beginning, how much you recommend? Less than 1.5.
Yes, sir.
So it's matter of 50 cases. So do you think what is the most difficult case for you in RIRS? Not big stone, location.
Inferior calyx with the inferior calyx, and it's medially medial part of the.
More medial, more inferior calyx. Don't do it. Don't try to do it with your heart and break the stone. Break the stone. How do you say that stone is medial? Any clue on RGP?
Sir, it is parallel near to the spine and parallel to the ureter. We can say that.
Yeah, nearer to the ureter. Nearer to ureter.
Yeah, to it.
Nearer to spine. Parallelness.
Yes, sir.
All these are very, very good points. Better in the beginning only do PCNL, explain patient, take less money and be happy. And don't try to meddle half an hour with RIRS and then go for PCNL. You know what will happen? All contrast will intravasate and you will not get good RGP and you will not be able to puncture properly. Then it is both the sides you will mesh up. Lower calycial stone is equally difficult for medially located, is equally difficult for prone PCNL also.
Yes, sir.
Unless it is seen very big so that you can hit the stone.
It's
If
a stone
it is
puncture.
very big stone, it is very difficult for prone PCNL also. I think these are the points, very important. How long you will give the antibiotics post-op, in your hospital?
Yes, sir. 3 days we'll give the IV antibiotics, sir. Then I will start
days.
over 3 days.
3 days, why? We are not giving 3 days. On the day of surgery, you will give. On the night, you will give. Next day morning, you will give. Next day night, he will going home.
Yes, sir.
If he has urine culture positive,
then.
Preferably it should be sterile. Do you recommend urine culture in all cases of RIRS?
Yes, sir.
100%.
100%.
100%. That is also one factor which will make you aware that you should not go beyond your limitations, isn't it?
Yes, sir.
Yeah. After surgery, if the patient gets high grade fever on the first day, what will you do?
Sir, first I will check the culture report whether he's getting adequate antibiotics or not,
Very
and
good.
we try to upgrade the antibiotics if possible.
What antibiotic you are giving routinely?
So we are starting with the Magnex, cephalosporin sulbactam initially.
Cephalosporin and sulbactam. After that, what will you give?
Piperacillin tazobactam we are giving, sir.
Blindly, we will go for piperacillin tazobactam. If that also doesn't work out,
we'll go for meropenem.
Meropenem. But this transition should not be very fast.
Very
not
fast.
hourly, 2 hourly. You have to
After
wait
24 hours.
If the patient, what are the other features like total leukocyte count?
Total leukocyte count, febrile episode, how much temperature he is getting, and also.
Yeah.
So after 3 days of the.
What is the most common investigation if doubt post-operatively you do on the bedside? What investigation you will do?
We'll check for the ultrasound, sir. Any residual is there first of thing.
Yeah, extravasation, perinephric hematoma.
Recollection is there anything?
Stone, stent position, everything we can see in ultrasound. These are also very basics. If you have radiologist, you can request, sir, please see a patient is having fever, tenderness. Kindly please see in the RIRS we have done like that. When do you remove the stent?
Sir, normally we'll remove after 2 weeks, sir, stent. If the patient is getting any febrile episode or anything, we just check with the ultrasound for any CT. If there is no residual.
Ureter avulsion in your unit?
No, sir, till now I didn't see.
What is the main reason? Tell main reason why ureteric avulsion you have not seen. I have not seen in 20 years. Sorry, but touch wood, I have not seen. Why? Afraid of ureter.
Yes, sir.
And stent whenever in smallest doubt.
Yes, sir.
And stop the procedure when smallest doubt. Because patient will never die with small stone. Patient will never die with small stone. Even if you leave, nothing will happen. Somebody else can treat. But don't try to forcibly insert the ureteroscope, forcibly insert the access sheath, forcibly remove the access sheath. Can you remove the access sheath very fast?
No, sir.
No. You have to pass the obturator. You have to pass the guide wire.
Guide wire.
Only front and back, front and back, front and back, front and back, front and back movement. millimeter by millimeter, you take it out. Do you apply Zalocan jelly to access sheath?
No, sir.
No, because it dries up and
Stick it dries, sir.
it sticks. So what will you apply when you inserting the access sheath?
It's only water. So the hydrophilic coating will be there. So only water will.
Only water will be applied. So you should not apply the Zalocan jelly. What guide wire you used normally for all these cases?
3-2 guide wire we'll use.
0.03 to thermo guide wire.
Yes, sir.
It easily passes. What is the disadvantage of thermo guide wire?
It slips off easily, sir.
Slips off easily. If the water is not at all coming out during flexible ureteroscopy, and if you try flex access sheath above, below, and a kink is there, and you cannot pass the access sheath beyond the kink, it is already post-stented, what will you do?
We'll keep a needle in the PCS, sir, like a supine pencil puncture, and that will drain out the thing.
You got trapped with my question. I thought I will trap you. That is where, in a beginner, do PCNL. Why are you telling needle?
Yes.
Needle business may be difficult. If your ureter is post-stented, water is not coming, kinks are there, your access sheath is not going beyond the kink, you are having fast problem, no needle business. Put ulta, prone PCNL or supine PCNL, remove the stone, put a stent and come out safely. See, this is what exactly today what I wanted to convey. So many seniors are saying that access sheath ureteric injuries are happening so commonly. It is correct. It is we have to prevent that, because when we are doing large volumes, when we are telling to any junior, you should always tell easy things, not difficult things. Do you think putting a small needle in supine while doing RIRS is easy?
No, sir.
No. Very difficult. Ultrasound is required, RGP is required, and patient not in supine position, is not in tilted position, already draped, you have to remove the drapes, then do PCNL now.
Yes, sir.
Why unnecessarily take that type of risks? Okay, if you wanted to show it off or you are very senior confident, it's okay. But as much as possible, respect the PCS. Kartheek, I want to ask you a question. How much water will you use in a RIRS case normally? So 20 ml syringe you flush na, or
yes, sir.
use na.
Gravity method will do, sir.
400 ml, 500 ml, 600 ml, approximately.
500 to 1000 ml, sir.
500 to 1000 ml, correct answer. So if the water is not coming out, what is the capacity of the pelvis of the kidney?
10 to 15 ml.
500 ml where 10 to 50, where will the water will go if the water is not coming out? It will
extravate.
Where? Around the kidney.
Perinephric
Entire kidney, if you do laparoscopy, entire kidney will be flooded with water. Gerotas fascia and kidney will be flooded with water, 1 liter water, the abdomen. Even ascites can occur in children. I have seen ascites.
Yes.
So perinephric collection, rupture of the kidney, rupture of the calyx, perinephric hematoma, ascites, periureteritis, edema around the ureter, very, very common. We don't see. That's why we see only the lumen.
Yes, sir.
Going on. Kidney will become like a clogged, soft structure. Now people are saying that after 1 year, if you do function, that function is gone. Dangerous, na?
Yes, sir.
The kidney is atrophied because of the pressure for 1 hour. That means the first point you told, water outflow should be free. We have done a study where if water is 700 ml gone inside, you know how much water will come out normally? 640, 650 will come out. Where that 50 ml gone? Definitely into the kidney.
50
ml it's okay. But if it is more than 100, 200 ml, pressure will be there in the kidney and sepsis can occur. For example, in PCNL, you can give blood transfusion. In sepsis, after meropenem, what will you give? What will you give? Teicoplanin. Teicoplanin, what will you give? You have to raise the hands and pray the God. That's why RIRS sepsis is more dangerous than PCNL bleeding sometimes. I'm not exaggerating. I'm telling truth from my heart. But thing is, if you learn properly and do properly, RIRS is less invasive surgery. Even in children we are doing. The only answer is stent, avoid kinks, proper placement of sheath, no force, no forcible withdrawal, no long duration more than 1 hour surgery, do RGP at the end, give diuretics, give if you want short doses of steroid also, controversial but it is useful, maintain water input output balance, don't discharge early, give antibiotics for longer time, and ensure that the patient does not have fever or urine culture positive. They are all very, very important. Always do the small stones, small stones. RIRS is for small stones, small volume. Even 8 mm upper ureteric stone, 6 mm kidney stone, 8 mm kidney stone are best cases for RIRS. Even if you do 4 or 5 pieces and put stent, they will come out. You will not do damage. But if you take 1.52 centimeter, you will spend a lot of time and regret, and scope also damages, all the problems will be there. That's why I have given this topic. I hope the audience appreciate that, and you have done very well. And
Thank you, sir.
go slowly, steadily. You can do up to 3 centimeter also. That is not great. Doing a large stone is not great. Doing safely, the stone is the great. Large stone is not great. If you do 2 hours, any stone will disappear. Kidney also will disappear.
Yes, sir.
So we should not do like that.